Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Risk of Asynchronous Contralateral Breast Cancer in Non-Carriers of BRCA1 and BRCA2 mutations with a family history of breast cancer. A report from the WeCare study by Anne S. Reiner and colleagues. My name is Stephen Nayrod, and I am the director of the Familial Breast Cancer Research Unit, Women's College Research Institute in Toronto, Ontario, in Canada. I'm also a professor in the Dalla Lana School of Public Health at the University of Toronto in Toronto, Ontario. My specialty is the genetics of breast and ovarian cancer. It's now well established that women with breast cancer and a BRCA1 or BRCA2 mutation are at high risk for developing a second cancer in the opposite breast. On average, following the diagnosis of the first breast cancer, the risk is about 2% per year or 20% over a 10-year period, but the risk varies between women. The risk is particularly high for young women, notably for those diagnosed at age 40 or below. The risk of contralateral breast cancer is also lowered by several of our current breast cancer treatments. These include tamoxifen, chemotherapy, and oophorectomy. For many women who carry a BRCA1 or BRCA2 mutation, the lifetime risk of a second breast cancer is above 20%. And these women often choose to have a bilateral mastectomy as a means of reducing their risk. Bilateral mastectomy is the most effective way to reduce the risk and is increasingly being used in many American hospitals. But its use is not restricted to BRCA1 and BRCA2 carriers. By and large, most bilateral breast cancer surgeries are done in response to a request by the patient herself who's concerned about her risk of getting a second cancer. Many physicians who would not normally raise the issue of bilateral mastectomy will nevertheless comply with the patient's request and will perform the operation when asked. In order that the decision for a contralateral mastectomy be based on the best possible information, it is important that we have accurate figures about the actual risk of a woman experiencing a contralateral cancer. In particular, we are interested to know about risk in women without a BRCA1 or BRCA2 mutation. Are there subgroups of women with breast cancer but with no mutation who have a high enough risk of contralateral cancer, say 20% lifetime, that contralateral mastectomy should be discussed? In the article that accompanies this podcast, Anne Reiner and her colleagues report on the WeCare study and compared women with bilateral breast cancer with those who had cancer in one breast only. In this study, they concentrated on women who had been tested for BRCA mutations, but no mutation had been found. Using a case control approach, they set out to try to identify factors that predicted a contralateral breast cancer and then generate risk estimates that can be used in the clinic. They found that both a family history of cancer and an early age of diagnosis were important risk predictors. The risk of contralateral breast cancer was particularly high for young women, those less than age 45, who had a first-degree relative with breast cancer. Another high-risk group was women who had a first-degree relative with bilateral breast cancer. The 10-year risk for women with no family history was 5%. For women with a first-degree relative with breast cancer was 9%, and for women with a first-degree relative with bilateral breast cancer was 16%. Of course, the lifetime risks are much higher than these 10-year risks, but we are not given these figures. which of course are the relevant ones for the women deciding on whether or not to have a bilateral mastectomy. Also, all of the women in these families were relatively young. The index cancer in each case was diagnosed at age 54 or younger, and so we cannot be sure about the risk for bilateral cancer for women diagnosed after age 54. The results of the WeCare study are no doubt of practical value and can and should be used by surgeons and by genetic counselors who are discussing bilateral mastectomy when women are newly diagnosed with breast cancer. It would also be interesting to compare the risks of ipsilateral breast cancer in women by family history of disease. A second issue of clinical importance is to estimate the risk of breast cancer in a daughter or a sister of a breast cancer patient. For example, consider two women both diagnosed with breast cancer at age 50. Both are treated the same way. One woman develops a second breast cancer at age 55 and the other does not. Each has a 30-year-old daughter. How does the risk of breast cancer in the two daughters compare? Presumably, the risk is higher in the daughter of the mother with bilateral cancer, but is the risk difference sufficiently large to be meaningful and to lead them to pursue different screening strategies? Is the risk high enough to consider preventive surgery? According to the WeCare study, about 8% of daughters in this situation will carry a BRCA1 or a BRCA2 mutation and will be candidates for mutation testing if it's not possible to test the mother. In the event of a negative test, how high is the risk? What I like most about this WeCare study is that other than the original testing for BRCA1 and BRCA2 mutations, all of the results and the risk estimates are based purely on family histories and on clinical notes which are available to the physician. There's no need for SNPs, single nucleotide polymorphisms, or for testing of rare genes to generate risk estimates. Nevertheless, the conclusions are logical, consistent, and important. This study emphasizes the need for a good family history to be taken from each woman with breast cancer, including her first and second degree relatives, with special attention paid to bilateral breast cancers. In the era of personalized medicine, we should not forget this simple message. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.